Good morning, everyone, and thank you for joining. I'm Dr. Allison Arwady, the Commissioner at the Chicago Department of Public Health. This is your chance to get your COVID questions answered. We are taking questions live. You can either put them into the Facebook or the Twitter, hashtag AskDrArwady, or just in the box below. Today is Tuesday, August 18. Thanks for joining. We have a special guest today. This is Massimo Picilli. He is a Chicago Department of Public Health employee, and he is in charge of all things related to testing. And I know that you all have lots of questions about testing because every time we do this program, we answer questions about testing. Massimo has a background in science and lab work, and why don't you go ahead and tell folks just a little bit about yourself and about the work you've been doing at CDPH prior to COVID, and then what you've been doing since COVID, so that they know what kind of good questions to ask you.
Sure. So currently, along with Dr. Ginai, I co-lead the testing and laboratory surveillance component of the COVID response, and that's really coordinating the activities and the work of many that really do the work of responding with the surveillance data and everything that's related to testing and anything lab-oriented.
Yes. All things laboratory. He's our guy.
And then really, if I think pre-COVID, was really much of that work applied within our communicable disease program that does the work of investigating and responding to reportable conditions as well as cluster and outbreaks. And so that's the work of the investigators, the epidemiologists, our medical directors that sort of do both the surveillance and the response components of that work. And of course, COVID response fits quite nicely into all of that.
It does. And how long have you been at the health department, and a little bit about your background?
Sure. So I was born and raised in Italy. I've been in the US for a little while, but ESL may kick in, so fair warning. I've been at the department now for 8 years, and I have a past in biochemistry. I had a graduate degree in chemical biology and one in public health. And that sort of, all of those things together led me to this position that's sort of a coordinating point for surveillance and response.
All right, perfect. So if you've got questions, especially related to labs or testing or how data fits into that kind of work, Massimo's our expert. So let's check our social distancing. Just as a reminder, we've got very good distancing today. This is one of your best ways. You know, we really want folks wearing those face coverings and then keeping that 6-foot distance. Think about you being able to do this for everyone around you and the other people being able to do that. If everyone can do that, you've got good social distancing. That's one of the absolute best ways you can continue to protect yourself against COVID. So let's turn and do a quick data update. You can start putting in questions and we'll come back and get them. Okay, so let's go to our data dashboard. As always, you can go to chicago.gov/coronavirus. That is our overall website for all things COVID. Up at the top, under latest data, you can get the whole range of different types of data we have available. You can also get directly to the dashboard by going to chi.gov/COVID-. We update it every day. I look at this thing multiple times a day, and I encourage you to explore it. So if we take a quick peek at the landing page, first of all, you can see that our current positivity rate, using the test positivity rate, like the state calculates it, is at 5.0%. We want to get that back under 5% if we can. You can see last week we were at 5.2%, down just a bit, but still higher than we'd like it to be. Our daily case average is at 307 cases per day. You can see a week ago it was at 302, so we're up about 2%. We've been sort of holding steady just over the 300 mark. And I'm going to take it over to the daily demographics here. And you can see on this chart here on the upper right, this is what our overall kind of epi cases look like. Had that very big spike in May, came down really nicely, and then just have continued to slowly trend up. Not shooting up in a way that's very concerning like we've seen in a lot of other states, but still not quite turning around. And we would like to start seeing that move in the other way. I'll also note here that our number of deaths per day is actually down to 2 deaths per day. We've been seeing that continue to drop, and similarly, our hospitalization data continues to look very, very good. There are many days where we're actually setting records in a good way for the few number of people still that are seriously ill in hospitals here in Chicago. That said, we do still have dozens and dozens of people, unfortunately, critically ill with COVID in Chicago hospitals. So it's not the time to let down our guard at all, but we continue to watch all of this data. I will just highlight very quickly, I'll see how you can move this bar here and look at just for the last month. Let's look and see what's happening with age. So where we click here, you can see on the top, that red line are our 18 to 29-year-olds. You can see still from a case rate, our most frequent is in that youngest group. But it's sort of flattened out a little bit. We're maybe making a little bit of progress, and we're seeing our older groups down with a much lower case rate, which is good. That's what we want to see. We obviously are concerned about younger people, both that they can become seriously ill, but especially if we see transmission to folks who are older or have underlying conditions, that's when we could start to see more hospitalizations. So one good piece of news so far is it looks like a lot of these younger folks are doing a pretty good job of being protective of their parents and their grandparents and, you know, their older neighbors and people with underlying conditions, but we continue to keep a close eye on that. So I think that's all we'll do today on data. I encourage you to take a look yourself. We're actually doing a press conference at noon today to just give some updates about travel orders and more about data. So if you're interested, you can tune in for even more. But let's turn back. I'm going to go ahead and pull up some questions. Oh, we're already getting things in. Perfect. So maybe before we dive into a specific question, what kind of questions do you get a lot about testing? You know, when you're out and you're telling people, I work at the health department and I work on testing, what are some of the common things you hear?
Sure. I think there are a lot of questions around what types of test,
yes,
and then who should get tested.
Yes.
I feel like those are the two really big buckets, right?
Absolutely. Good. Let's take them.
So for the types of test, I think, you know, we have this saying in the team that it's the right test for the right person at the right time and for the right reason. So we can dig into that a little bit. So in terms of test types, we think really about two big buckets. We have testing that is for diagnostic purposes, it aims to identify the currently infected individual. And these are tests that really, you know, I'll divide them in two buckets, but they really aim to pick up the signal of the virus present in the specimen that's collected from us. And sort of the one that's used most broadly for diagnosis is molecular testing.
Yep.
And that is picking up the molecular material, the RNA of the virus that is present in mainly respiratory specimens.
Right, nose and mouth swabs.
Yeah. And so those those tests go in, seek that signal of the molecular material and sort of flag it. The one that's used most broadly and sort of like the standard is, it's called a polymerase chain reaction. So what it does is cycles through the sort of this process sample to amplify that signal and pick up that indeed in that specimen virus was present.
Perfect, and that's PCR. You'll sometimes hear that. That's the polymerase chain reaction, looking for the genetic material.
And the chain reaction is really like that cycle of breaking up that material, tagging it to something that can be recognized by the instrument, and sort of like the flag goes up and it's positive. And then we also have antibody tests. Antigen tests. They're related to diagnostic testing.
Yep. And we had, just for some awareness, we got a question about the Ohio governor and his false positive. I think last week that was an antigen test. So.
Okay. So antigen tests do something similar. So they aim to pick up the signal of the virus in the specimen. So again, similar type of specimens, nose, throat type of specimens. And they aim to pick up now, instead of the genetic material, the protein that are related to the virus. But again, picking up current infection in currently infected individuals.
Yep.
So that's the bucket of diagnosing currently infected folks.
Perfect. That's the one. When people have symptoms, we'll talk about who gets it. But all right.
That's what we're talking about when we're talking about positivity rates.
Right.
We're talking about the molecular testing. Really.
Exactly. Yeah. We don't put the antibody tests in there. We're just putting people diagnosed right now with COVID.
Right.
Perfect.
And I guess then the other bucket is this antibody test.
Yes.
And that is really poorly suited to identify the current infection, because that test seeks the signal of our response to the infection. So it's really the specimen here, it's either serum or our blood, And it's picking up of those antibody response that, given our system was challenged by the infection, it then mounts this response, and that signal can be picked up.
Right.
It takes a little bit of time for that signal to come in. So again, that's the reason why it's really poorly suited to identify current infection, because somebody could be currently infected and not yet have antibodies that would be detected with this type of tests. So these tests are
and those are the blood tests.
Those are the blood tests, antibody tests. And so those are a complement to the other type of tests, but they're to be used, that's the idea of like the right test for the right reason.
Yeah.
They're to be used in sort of, they can be useful in identifying prior infection on individuals that perhaps did not have the opportunity to receive the molecular test.
Yep.
Or they can be distributed, sort of performed at a population levels to identify distribution of disease. And they're also helpful to identify individuals that may be eligible to donate plasma.
Right.
And sort of having that signal of the antibody response in that individuals may make them eligible for that, which can be important for others who may be affected.
All right, perfect. Yeah. Perfect. We're already getting questions, so I think let's dive in, and then we'll hit some more on this. So, Tony Lee Kwiatkowski Crowley on Facebook. Do we have testing coming to Chicago that will have quicker results, like the testing for influenza?
That's a great question. So we were talking a little bit about the methods of the testing.
Yeah.
But there's also sort of the technology of the test, right? And so when we talk, now let's talk about molecular testing. That's the type of test that we collect a specimen somewhere, and then off it goes to a lab, oftentimes quite far away from the specimen was collected.
It might go to a hospital, it might go to a commercial laboratory.
Yeah.
You collect it somewhere, you mail it off basically, or drop it off.
And sometimes some of these big commercial labs are regional or even national, so it has to travel quite a bit. And once it gets there, it's in line with many other tests that others will have ordered. So those tests may take a few days, and we always keep an eye on sort of how long it takes for a test to come back, just to have a sense, because again, this is information that is informing clinician, and then of course it's informing us in the response in the context of investigation and the contact tracing. So we want that period to be as short as it can be.
Right.
But recognizing that this framework takes a little bit of time. Now, there are other tests, there are point of care tests, where the specimen collection and the instrument is sort of sitting right there in that clinician's office, perhaps. And so that turnaround time can be quite short. Now, some of those tests sort of may perhaps be not quite as sensitive, and so sometimes they require a confirmation of the other test, but they can certainly be very helpful if they're positive and they elicit that sort of intervention right away.
So that would be like the flu, the rapid flu type test.
Right.
It's the same idea roughly, right?
Exactly. And so there's a ton of innovation in this type of space. There's certainly some, both molecular tests that are approved by the FDA to be sort of validated for this type of use. They're just like the molecular tests we were talking about, but they do that reaction a little bit different. Instead of being a PCR, it just sort of one shot at one temperature sort of thing.
Yep.
And so the turnaround time is quite short. And then there are similar point of care tests for antigen testing. Again, similar to the flu idea there.
Right, right. All right. So are these here in Chicago?
They are. So they're everywhere. And I think sort of distributed across, like, one of the best ways to get tested is part of the clinical evaluation as a clinician. I hope you'll endorse.
Jump in there, yes, absolutely.
And so going to your clinician asking for these type of tests, recognizing that the ability, the availability and sort of the landscape has certainly changed over the past months, but they're increasing sort of availability of testing, availability of multiple ways to get tested, and multiple methods. So I think starting with the clinicians to identify that which is available, and then we certainly have opportunities with other settings in Chicago. We have our federal qualified health centers that do a lot of testing for Chicago residents. And then of course the Chicago Department of Public Health, the city is really supporting community-based testing with molecular testing that is also available to our residents.
Right, and so if you go on the website, chicago.gov/coronavirus, you can find information about the city's testing, you can find information about clinicians, but we always tell people, really the best bet, if you have a doctor, if you have someone where you get health care, that is your best place to start. That's the team that knows you, knows your conditions, knows how to help navigate testing, and then especially if you turn out to be positive, we want to make sure you're connected in with a healthcare setting most ideally. So I'm seeing this kind of stuff pop up. Brenda Johnny LeBron on Facebook is again wondering, are these tests already being used and where? There's a car dealership very near my house that literally in the last week has turned into a testing center. It closed as a car dealership and now it's set up and that's not free testing. That's set up for they're taking insurance or people can pay, but they've got all the kinds of testing there. They've got the PCR, the molecular testing. They've got some rapid testing. They've got antibody testing. I think every week we're seeing new technology emerge and working hard at the health department to make sure that there's good awareness for where to get things. So, a lot of the the urgent care places in Chicago, for example, may be a little more likely to have some of those rapid tests, right? It just kind of depends, and it all fits in a little bit with what your insurance status is, what your, do you want to speak a little more to that?
Yeah, and I guess what made me think of sort of the difference with some of these, if we think about one individual, it's true that sort of having that rapid, like each test method comes with some trade-offs.
Yeah.
And so the rapid test, we were discussing a little bit about the sensitivity, but also how many you can do at a run.
Yes.
Like those are benchtop instrument, you do one specimen at a time, so they're suited for this type of urgent care setup.
Right.
What we were talking about earlier with this setup where the specimen is sent somewhere else, those are often much larger labs. And so it takes a little bit of time for the specimen to go there, but once they're run, hundreds of tests can be run at the same time.
Right.
And so each of these components is sort of suited for sort of different settings and different situations.
Exactly. So if we're wanting to test hundreds of people, these point of care tests can take 15 minutes to sort of do one. You can only test one person at a time. You would not want to set hundreds of people up and have them sort of waiting 15 minutes at a time. If it's a setting where generally you're in good control and maybe you're occasionally doing a testing, it might make more sense there. So these are some of the things. Faith State on Facebook is wondering, when people take at-home COVID tests, are those results included in city statistics if they live in Chicago?
Oh, great question. So I guess you review data with us all the time, and it's really invaluable to have this information to inform that which we do, right? And I guess all of those data are funneled through our surveillance system. We can think of like a funnel. Like all of the laboratories and providers contribute to the system, and it goes into the surveillance that we see. Like those data that we see are reflected on the dashboard, et cetera. And so if they are tagged by the residents of the individual, so for as long as the provider and our lab are plugged in and reporting to public health, we see all of those data regardless of which provider, which laboratory conducted the testing. And that includes sometimes the commercial laboratory that is performing the test in a different state. But if that is for Chicago residents, we will see those data and they're reflected in the data.
Yeah, that's right. It is the law that any diagnostic COVID test that is done must be reported to the health department. We find sometimes with some of this newer technology, like for example, when you're running these rapid tests, like if you've had a flu swab at a doctor's office, or you think about a pregnancy test where we think about these really point of care tests, someone's literally, dipping for a pregnancy test, for example, you're dipping the urine, you're sort of getting a positive or a negative. There is no computer attached to that test that is reporting that result. And in the same way, these point of care tests for COVID, similarly, it's not like when a commercial lab or a big hospital lab, runs a lot of tests. They have a big tech system that makes sure you're keeping track of the test results and the patients, and you're sending those results back to the ordering physician, you're sending it to the health department. These point of care tests are actually dependent on the provider or the person who's doing the test doing the right thing and not just telling the patient you're positive or negative, but actually entering the information to get it to public health so we keep track of it. So broadly speaking, when tests are done, particularly if they're positive, they all get reported to us as long as they're a Chicago resident. And if it's a diagnostic test, they all show up in our data. We find sometimes negative tests might not get reported. They also have to be reported, but sometimes they don't get reported as much.
Yeah, and just as you were describing, the contribution into the system come from so many different partners. Some of them, however, like the best and more reliable way to get those data is to get them just plugged in electronically,
yes.
right? And so
nobody has to do any data entry.
It just automatically happens.
Yes.
Like the data is just pushed out. And so that is what we call electronic laboratory reporting. And it's those are the hospital-based lab of these large commercial labs. They're all directly plugged into the surveillance system. So they contribute hopefully 100% of those data, right? Because they just come through 100% of the positive, 100% of the negatives.
Right.
And those are the reliable sort of indicators that we use for that percentage positivity.
Yeah, and then those positive tests, that is how we then do case investigation and contact tracing, right? So it's not just getting the test done, it's getting it appropriately reported into public health so that we can do that next step in terms of controlling it. All right, Margaret Quinn on Facebook. What level of concern do you have about false positive testing? Do you feel confident that positivity rates are an accurate measure for reopening guidelines? Kind of two questions in there.
Okay. So in terms of the concern, so for any testing, they're always evaluated for this very component, like
yes.
how predictive are they to pick up a true positive and a true negative? That is the goal, that is what we want of a test.
Yep.
That when somebody is infected, it flags positive, and somebody doesn't have the infection, it flags negative.
Right.
And so each test is evaluated because there may be instances, there's sort of like a distribution of results, and there may be instances where there are some one-offs that don't quite fit in the right bucket. Mm-hmm. So we want tests that are very, very good at predicting, again, the true state of the individual.
You don't want false positives, you don't want false negatives.
Right. And that is sometimes called the sensitivity and the specificity mm-hmm. of the test. Mm-hmm. In terms of the COVID-19 diagnostics and some of the tests we were talking about, we really have quite, they have very good sensitivity. So like specific to the question, we don't often have concerns of false positive.
Right.
We can truly rely on that positive.
You get a positive PCR molecular test, nose, throat, like you're positive, you're positive.
Yeah, because again, it's picking up that signal in the specimen. So
yep.
either, certainly for the molecular test, but even for the antigen test, the positive is quite reliable.
Yep.
It's really picked up that signal.
Yep.
For the negative test, I think that's where it's the right test at the right time
yes.
for the right reason comes in a lot. Because it's not only the performance of the test, but it's also the timing of the test.
Precisely.
And the quality of the specimens that we use to pick
yep.
up that signal. So while a positive is sort of quite reliable and we take all the actions we take in terms of response, investigation, contact mm-hmm. tracing, and all the things as individuals that we do in isolating ourselves, mm-hmm. a negative doesn't remove doing all of the right things that you often tell us to do, right?
Yes.
So quarantining if we have had an exposure regardless of a negative result. Again, because that signal is just that one result at that one point in time. So a negative result may also be the outcome of not collecting the best specimen or not collecting it either too soon or too late. Where it will not pick up that signal quite
yeah, so let's talk about collecting the best specimen.
Oh, sure.
Talk about what that means.
Yeah, so there's sort of a match between what is the approved specimen for each test.
Yep.
So when we go to a provider that's sort of established for us, we don't have to make those decisions, others make them for us. And the FDA actually that validates, so that sort of approves testing methods, also sort of approves it with the combination of which tests are approved along with that specific, which swabs,
yes.
which specimen type are approved with that specific
yes.
test. And so early on, I think we did a lot of that sort of deep into your nose and throat, the nasopharyngeal swabs. Mm-hmm. But now there are many other swab types that are approved. So the oropharyngeal, that's sort of like the inside of your mouth.
Yep.
We also have nasal swabs. Saliva type
yep.
specimens are being validated as a new sort of more adopted methodology for picking up the signals.
Yeah, and when you think about this, right, like early on, you really, I mean, I've had to, as a doctor, I've had to do these tests, and I've had these tests done to me related to COVID, but also like when we were doing Middle East respiratory syndrome investigations, for example, like I was doing field work and going and like literally having to do this like in households and in clinics, even in Saudi Arabia. And you really have to get it high up in there. Like it's not very comfortable. Otherwise you risk really not getting a good sample, and someone could have COVID and you would have a false negative. So I've been very pleased to see the advancement where, we're getting better and better, availability of ways that are not as uncomfortable for people and not as hard for clinicians. You think about, the clinician, that's a harder test to do. You have to wear more personal protective equipment. You're gonna make people cough. There's higher risk for infection. So some of these slightly less invasive ways are one of the things I've been really interested in seeing develop some more.
Yeah, and that's really sort of the outcome of that evolving landscape of testing.
Exactly.
Right? As we know more, as the methodology gets better, it sort of may be more suited to collect some of those other specimens that are less invasive and easier to collect.
Yeah, good. This is a good one. How does the FDA decide if a test is good enough?
So FDA approves diagnostic testing and certainly has done so for COVID-19. The process, there are sort of two lanes of approval. One is the true sort of FDA approved test. That process takes quite a bit of time. In the context of a rapid response like we're having now for COVID-19, but this is really just a general mechanism. What's in place is this emergency use authorization. And so it's an interim step that really does the same work. FDA establishes standards that have to be met by anyone who is sort of developing a testing method. And there's a standard about what type of data has to be submitted. It is independently reviewed, and then FDA publishes publicly, bestows this emergency use authorization that allows sort of the performance of that test.
So like if I develop a test, I have to do it on a certain number of people and show were they truly positive, were they truly negative? Is that kind of the idea?
Exactly.
Yeah.
And in fact, you also have to do it in the right proportion of people. Like within those data, the amount of results they are submitted for this evaluation, there have to be a certain number and a certain proportion of those that are positive and a certain proportion that are negative to do that very thing we were talking about, to evaluate that sensitivity and specificity of the test.
Yeah, all right. And you can find out on the FDA website extraordinarily detail about any test if you really want to. All right, we're getting kind of a range of some other questions too. Lisa Tsakopoulos on Facebook. Is it true that the companies that are working on the vaccine have completely skipped animal trials? Why, and is this not dangerous? So I'm going to start on that one. No, the companies have not skipped animal trials. When we talk about the vaccine updates, when I give those, I specifically focus on the ones that are already in human testing. But before they get to human testing, there's a lot of lab-based testing and animal-based testing that goes along with that. So before you can ever move even into phase 1 of a human trial, that's when, again, reminder, when we're just checking, when we're testing a vaccine in a very small number of people, basically working to make sure it's safe and start working on dosing, that comes after a significant amount of animal trials. And that is true for all of the COVID viruses, all of the COVID vaccines, of which there are almost 160 that are being worked on around the world. Anything you want to add to that?
No, just as you said, it all starts in the lab to sort of build some evidence, but then all of the work is really built into these successive rounds of evaluation for that safety and efficacy. That takes some time and investment.
Yep, absolutely. Joan Galima on Facebook. Can we get the virus through open wounds on my hands? Good question. Basically, no, you can't. We continue to obviously learn about this virus, and we've not seen examples of it being spread sort of via bloodborne, via wounds. I never want to say something is completely impossible because we continue to learn about the COVID virus every day. But broadly speaking, when the virus gets into your body, you could imagine if you had a cut or something, theoretically virus could get in, but it's not just about can the virus get into your body. If the virus gets in, it also has to hit a cell that has the right kind of receptor for the virus to actually get into the cell and start to replicate. And so those kinds of cells, those kinds of receptors are in our respiratory system, in the system in our nose and in our lungs. And so you basically need to get COVID virus into the respiratory tract for it to be a big concern. So that's why we don't worry about virus getting in through the skin or through little cuts. We don't worry about mosquito transmission. It's different. There are, Ebola, for example, when we talked about that was a virus that absolutely can get in through cuts. We worry about it. This one, respiratory virus. So, if you've got a cut, wear a Band-Aid. There's other reasons to keep it covered, but I would not have major concerns at all about COVID transmission. Okay. Mary Rodriguez on Facebook. I've seen an article about gators worn as face coverings, I saw this too, being worse than a mask. Do you think that's valid? Did you see this?
I did.
You want to comment?
All I know, it was a report of the scope of, this wasn't really an evaluation of the effectiveness of the mask.
That is correct.
But it was really trying to evaluate which mask to give away.
That's right. That's right, exactly. So good question, and that is exactly right. So this was interesting to me. I think this was an example, this was a small study, it was done out of Duke, and they were really they had a very low-tech way using lights and laser and cell phone, basically a way of broadly doing some assessments of masks, not in a particularly controlled setting, just looking at different pieces. And there was, in this one very small study, it basically consisted of volunteers saying, I forget what they said, but stay healthy or something. And they would say it 5 times. And in the example of the one person who was wearing the gator, there seemed to be more potentially COVID, or not, they weren't even COVID, just more droplets. But let me tell you, even the people who did that study said this was not interpreted correctly. They said that was not the point of the study, that was not the conclusion. You can't make an assessment from one case, right? Perhaps the person wearing the gator has more mucus on his vocal cords, or he speaks a little bit louder, et cetera. It was not meant to really assess that. And because there was a lot of attention, actually some scientists have come along and tried to replicate that with some of the more controlled lab settings and have not found that gators do anything to sort of increase COVID risk, et cetera. The bottom line is I mostly want you wearing a mask. I mostly want you having your nose and your mouth covered, not just your mouth. The better sort of fit you can have around there, the better. It's pretty clear that sort of having 2 layers of fabric is generally better than 1. So a gator that's got 2 levels on it would be better. But at the end of the day, the one you will wear is the best mask. And for people who are wearing these and wearing them appropriately, please continue to wear them. I don't want people thinking that they're not effective. There might be slight differences in terms of the difference there, but nothing that makes a big difference in the sort of day-to-day setting. The most important is, do you have your nose and your mouth covered?
And perhaps the quality of the fabric is more so than the design.
That's right, yeah, more so than the design. You have a nice, we've talked about this a little bit, that you have a fabric, you want more the high-quality bed sheets as opposed to the cheap t-shirt. So, something that's just a little bit thicker, 2-layer. These work well. We've talked about this a lot on here, so we've seen that. Jennifer Clark on Facebook says, can you please go back to reporting the actual daily numbers in addition to the average? So you can always go to the dashboard, chi.gov/COVID-, and down on the bottom right, we put all of the data that we have as it comes in. You can hover over it and see what the data is for a given day. We report the data based on the day the test is taken. So sometimes you might get a test result back that same day. Sometimes you might get it back the next day, 2 days, 3 days. Maybe this is a test that's going off to a lab somewhere and it gets in a long line and it's taking more time to come back. We count it on the day the test is taken because that's consistent with when there is sort of COVID in Chicago. So you can go and you can hover to your heart's content and see what the actual numbers look like. That 307 daily average includes the weekend testing, which is always lower. Saturdays and Sundays across Chicago, across the whole US, we always have a lot less testing. And so we use a 7-day average to average out the number of tests that come in on weekdays versus weekends. It's always 7 days, and that average is really what we use to make decisions. Okay, man, we are almost out of time already. This is like so fast. I'm going to take just this last one real quick, or you can take it. Marilyn Fumagalli from Facebook. Are multiple positive tests on one person counted as new positives in the daily statistics?
So they're not.
Right.
And again, I think on the dashboard there are multiple opportunities to see those data.
Yes.
And sort of the part of the data that describes how many individuals are tested, or the distribution and the zip codes, all of that rich data is really one individual is one individual one time only. And so multiple tests for the same person would not be represented there.
Yeah.
There are certainly moments where we described sort of how many tests are performed,
right.
And that is from a test perspective,
right.
not an individual
Different
perspective.
from counting, and we only count individuals. So an individual gets counted once when you get a positive COVID test. So, all right. Well, thank you. Lots of good questions today. Massimo Picilli, again, is our expert for all things related to lab and testing. Anything you want to, we often will leave people sort of on a positive note, suggestions for the day or good things to do, or anything you feel you didn't have a chance to talk about?
Well, perhaps just that on the positive note, testing is more available in Chicago and nationwide,
Absolutely.
I would say. And so if you're symptomatic, if you have a confirmed exposure, if you're in a setting where the likelihood that you would have been exposed is higher, get tested.
Yes, please.
And as you were saying, a clinical setting to start with, there are FQHCs, and then there's testing that is supported in the community. And on the website, there's plenty of information on how to get there so that testing may be available to all residents who could benefit from it.
Yeah, and let me just add kind of to that good advice is that we really do not want people thinking that they can sort of test their way out of quarantine. If you have been told that you need to quarantine because you've had a high risk exposure to someone with COVID, within the 6 feet, no mask, et cetera, a negative test does not mean that you can stop that quarantine. Because remember, you can have a negative test early, the test can turn positive later. You need to do that full quarantine. And the other thing that we're seeing a lot right now is that sometimes people are going to get a test because they have symptoms or because they've been told they've had an exposure, and they get a test and then they just go about their life. And then their test comes back positive, like 2 or 3 days later. Not okay. If you are going to get tested for COVID symptoms, you must stay home. You must isolate while you're waiting for that test result to come back. You cannot continue to go to work. You cannot continue to go to school or go out and about. You're really at high risk for spread. And just because your COVID test is pending does not mean you're sort of out of the woods. In fact, remember, it's the law in Chicago. If you're even a little bit sick, you have to stay home. So, on that good note, thank you again for coming in. I will just highlight, I think for one other just kind of quick piece of good news, pridemasks.com has partnered with the city for a young children's mask design contest. So there's a My Chicago, My Future is a citywide program, and kids can draw, paint, or design on a computer. The theme is My Chicago, and there's one category for 3 to 6 year olds and another for 7 to 10 year olds. The Chicago's First Lady, Amy Eshelman, is going to be wearing this design, and they will also make some of these winning masks for people to distribute. So check out pridemasks.com website. The deadline to submit is August 31. So if you've got young kids in your life, get them designing a mask. That's a nice new example of a way to do that there. And I think I'll just end by noting that the health department is putting out quite a bit of additional funding related to mental health supports. $6.5 million will be out for bids from community-based organizations, from clinical providers in communities with high needs around mental health, from community-based organizations that provide mental health care, from community mental health centers. And some of that is city funding, some of that is COVID funding, but it's an exciting opportunity. And for the next month, organizations will be able to apply competitively for some of that funding. So you can check out the website if you want to learn more about it. Also watch for some press releases around that. But we certainly continue to put a lot of thought and resources into mental health here in Chicago, and particularly in the time of COVID. So I think with that, we will finish up. Thank you again for being here. If you can't get enough of COVID, we do have a quick press conference at noon today. And we will be back on Thursday with Sybil Madison, our regular, actually we will not. We will not be here on Thursday because I am taking a vacation. How about that? For the first time in a long time. And so this is it in terms of Facebook for the week. Keep putting in questions. We'll keep doing the one-offs and translating those into Spanish. But in the meantime, please keep doing the things that work. I hope when I come back next week, next Tuesday, we will be seeing those numbers come down just a little bit more. Now is the time when it's summer and we can be outside to get on top of this. So thank you again for joining.
Thank you.
And be safe, Chicago.